Ladies and gentlemen, I'm going to call the meeting to order. If you would, come on in, find a seat. Any of you folks in the back, if you want to move up and get a chair and be comfortable, you're welcome to do that. And if we close that door in the back for us, please. Thank you. Okay. I'm going to call the Subcommittee of Health Appropriations to order, and we're going to begin our public hearing today. And the first two presenters we have, we're going to be doing it virtually, then the others will be coming up to the podium and speaking with us in person. What I'm going to try to do is tell you who's up and then who's on deck so that whoever will be next, they can get ready and we can move along. We've got about 25 people who have signed up, and we're going to try to be as rigid as we can and not go beyond 5 minutes. If anybody is here with another group and you've already presented the information, you don't feel obligated to tell us again. And if you have some written information you'd like to leave with us, we'll be glad to take that as well. But brevity will be good. There's a lot of committees going on today. Some of the members are going to have to be sort of coming in and going out to other committees and everything. So with that having been said, we'll go ahead and begin. First thing we're going to do is hear from Archibald Medical Center, and this will be a virtual presentation.
All right, good afternoon. My name is Coy Irvin. I'm the Chief Medical Officer for Archibald in Thomasville, Georgia. And we're presenting today to talk about our new internal medicine residency that we're starting in July. We've been approved by the American ACGME to start the residency. We're going to have 5 residents per year, 15 total. And this is in response to the need for recruiting physicians to South Georgia and to Georgia, and try to build a primary care base of internal medicine to help us take care of the folks in South Georgia that need to be taken care of. We have had the benefit of Moultrie and Albany with their programs, and they've had about a 65% retention rate on keeping students in the area that they do the residency and then actually practice in Georgia and surrounding areas. So we think it's the right thing for Georgia. It's the right thing for our area, and we're excited to have it get started. We appreciate the time that you guys put in and everything you do to help us try to take care of the folks of Georgia. I wanted to introduce Dr. Palmer, who's our medical director of the program, to kind of give you just an update real quick of where we are. But the reference is to a grant of about $250,000, which would help us offset the cost of starting a program. As you know, starting up a residency program can cost several $1 million because you have to have everything in place when you start. So we are starting and excited about it, but it is, as is with most things these days, very expensive to get everything going. So at that, I'd like to introduce Dr. Palmer.
All right. Thank you, Chairman, and thank you, members of the committee. As Dr. Irvin stated, medical education in general, there's a lack of spots to train our young physicians across the country. There's, multiple medical students coming out that don't have an actual residency spot because there just isn't one available. I think the last statistics I looked at was somewhere around 4,000, medical students coming out that don't have those available spots to receive their training. So any, new training programs are going to be a blessing to this country, and specifically for the state of Georgia. So I'm very excited to be a part of this training program that's opening here at Archibald. I can tell you that the window is very short for us in terms of our recruiting process, secondary to timing of meetings through the ACGME for accreditation process. But I can tell you that in the short period of time of only a little over 2 weeks, we've had 464 applicants to our program, showing the vast excitement and encouraging numbers. I think we're going to recruit a very good first class. I think Dr. Irvin also alluded to the fact that majority of residents, when they complete their training, either stay in or around the area that they trained, or if they go off to additional specialized training, they return to their place of the original training program to kind of establish roots and practice medicine. The return on investment, really with medical education is so exponential that I don't even think it can be quantified. But clearly, in an area such as South Georgia, we need physicians. We have a great need for advancing our education training, and that's why we're presenting to you today.
If you have, we'd be happy to. We want to make it short for you. You got a lot to do, but if there are any questions you have particular, we'd like to answer those now.
Okay, thank you very much. We have a comment and a question here from Representative Taylor.
Thank you very much for being with us and joining us today. I just want to share, this is, they are from my district, and it is a rural part of South Georgia. They represent a 4-hospital assembly of healthcare. Without them, we would be lacking greatly in South Georgia without the care that they provide through their services. And they have done an excellent job recruiting a variety of different kinds of doctors, but this is an opportunity and they have stepped forward, and I'm very grateful, and our community is. So I want to offer my thanks right now for what you are doing and the efforts that it has taken for you to step forward to start this program. Thank you very much.
Thank you.
Thank you. Any other comments or questions from the committee? Thank you. We appreciate your presentation today. Thank you for joining
Sir,
us.
thank you. I'll have a great day.
Next, we're going to have Michael Halligan and Jay Collins. And any of you folks that are standing, if you want to be seated, please come up and make yourself comfortable with a chair if you'd like. You don't have to stand up in the back. Be glad to have you. After this, we'll have Claire Cox with Georgia Stomp. Stomp will be next.
Good afternoon. My name is Michael Halligan. I'm Vice President of Sales for a company called Pack for You. Our company is involved in a lot of state Medicaid programs to help improve health outcomes and lower the total cost of care using a virtual care service in the comfort of their own home. What we're requesting is funds to support a pilot for the use of this assistive technology to support people with chronic disease, with at-risk health conditions such as individuals who are pregnant or mothers with newborn infants, and to demonstrate that with this assistance for medication management and monitoring their vital signs with integrated telehealth, that we can help them not only with the access to care, but also where they may be residing, where there may be limited access to physicians as well as pharmacies. With this service, we also want to provide a benefit to the state. The health conditions that we are highlighting are ones that cost the state quite a bit of money with respect to both missed days at work, but also because of their conditions, they also drive a lot of costs to the medical system. The individuals that we'd be looking at may have metabolic conditions like diabetes and hypertension. Georgia has a significant higher prevalence than the national average. And as well, with respect to women that are pregnant, where they might have an untreated chronic disease, there's quite a higher rate of maternal mortality as well. I just have 2 more slides to show. One just shows how we connect everyone together. So we bring pharmacies together with physicians where people reside, whether it be in urban or rural settings, and help them to take their medications, and then have the physicians work with them through telehealth so that they're coordinated in their care as they try and live with these conditions. And lastly, I'll just show you what a member would receive. They'll receive a device in their home. It looks similar to what a family toaster would look like, with a high resolution screen on the front for them to interact, as well as devices that will measure their blood pressure, their weight, their body temperature, their pulse. Again, providing access to care without them having to transport themselves to and from appointments. It will track and monitor them to ensure they take their meds and prevent what is often described as anywhere between 33 to 60% of the reasons why people get admitted is a medication-related error. Thank you very much. That is my presentation.
Good. Thank you for your presentation. Do we have any questions from the committee? Thank you, sir. Okay, next we're going to be calling up, you have to help me with these names. Some of you don't write very well. And I can't read them. Claire Cox, maybe Georgia Stomp. And then next, Dr. Lucy Marion after that. Yes, it's podium, please.
Thank you, Chairman Parrish, for allowing me to speak this afternoon, and committee members. My name is Claire Cox, and I am Chair of Georgia Stomp, a statewide coalition formed to address menstrual equity and eliminate period poverty in the state. What started as a grassroots effort in 2017 has grown to 31 organizations with a reach of approaching 60,000 in our state. And I'm honored to have many members of the Junior League that have joined me here today for this meeting. They are one of our member organizations. This afternoon, I want to start by saying thank you for funding period products in FY22 for the Department of Public Health to provide to those they serve. Research shows that 1 in 4 women struggles to purchase period products due to lack of income. During COVID, that statistic increased to 1 in 5. We know anywhere poverty exists, period poverty exists. In 2019, the legislature allocated to DPH $500,000 for period supplies. Before that program could be initiated, funding was reduced, COVID struck the nation, and our public healthcare system was strained with previously unexperienced expectations. DPH faced the worst circumstances imaginable to start a new service to its clients. I won't go dollar by dollar through the allocation of funds and their removal, but it's been a little bit of a roller coaster. Thank you for reinstating the funding last year after its elimination. According to DPH officials, the department is on track to use the entire $200,000 allocation from last year. The funds have been encumbered and the products will be distributed. Recently, Dr. Toomey spoke to district directors on this issue specifically and stressed the importance of period product provision at local county health departments. I'm here today to ask that in FY23, you return the DPH Feminine Hygiene Grant to its original intended level, a $300,000 increase in the current line item. In conversations with leadership at DPH and local county health administrators, we have learned that the department's not been able to stock the supplies in a consistent manner such that districts can communicate period product availability and ensure the stock is on the shelves at a local county health department when someone asks. What is needed from the legislature is a consistent level of funding sufficient enough for local departments to implement this program. The DPH allocation was originally given as a partner to the allocation for the Department of Education. It ensures products are available to meet the needs of students outside of school hours, but the original intention was also to provide resources to anyone with financial hardships. Family finances have been devastated by the effects of pandemic. Services and products community health departments provide are lifelines for Georgians in need. Restoration of funding for the DPH to stock menstrual products on their shelves means menstruators in Georgia are healthy and can focus on getting back to work. So please return this line item to its original intended level of $500. Thank you.
Thank you. Any comments, questions from the committee? Thank you. Next, Dr. Lucy Marion, and be followed by Dave Lane.
Good afternoon. I thank you, Chairman Parrish and committee members, legislators for this time with you. I hope I'm speaking loud enough. it's wonderful to have this little bit of time. And I am Lucy Marion. I have been a nurse since 67. That's 50, almost 55 years. And I've been a nurse educator for most of those years, about 52 years. And so I started out with the usual floor nursing to end with Dean Emeritus from Augusta University after 15 and a half years there. 2 years ago, I retired. So I've got a lot of experience with workforce issues, and particularly nursing workforce issues, and it spans the level of those nurses as well. I am currently representing an advocacy group called Georgians for Health. And this advocacy group has been working with the Georgia Nursing Leadership Coalition, a group that was started 12 years ago to raise the bar on the nursing workforce here in Georgia. So, and I've been on that as well. So you may not know, but we now have 210,000 licensed nurses by our Board of Nursing. Licensed, that doesn't mean they're here or they're working or whatever, but just to let you know that to start with. So it's large. And also nurses span almost every setting, even work-life settings that you don't consider a healthcare setting. So nurses are there, churches and so on. So the data that we have to tell you more about the nurses in Georgia is very limited. It's very limited to a few demographics. And the data that we have about nursing education is non-existent. No, it's not really non-existent. It's actually in drawers and boxes and things like that in the State Board of Nursing. They actually survey every nursing program every year. And now we have 83, but it's not digitized in any way, it's in paper. So, and then when we look at where are we with understanding what's going on with nursing, where's the statewide plan? And when we look for that, we see some groups that have been working on certain aspects of nursing. Right now, we're looking at behavioral health, we're looking at rural health, and some other health where nursing will be looked at as a workforce. But we don't have anybody who is actually conducting workforce studies and facilitating modernization and so on. So we're asking for two things. The first one is to modernize our nursing data, both our education data and our relicensure data. And so we've written this up. This would be working as we have been working all along with the Board of Nursing and also the Georgia Board of Healthcare Workforce. So that because we deal with both of those boards, we're able to bring them together. So everybody's clear that it's time to modernize that. And we've been working with the legislature and the various agencies that they have. So we are asking for that. And so that would be for the licensure, that would be recoding more items. Right now, we only have the work. We don't have a work address at all, but we do have the zip code of the mailing address of the nurse. That's it. So, so we are asking for that project. And then the other one is to fund a statewide master planning process for 1 year. And you see the figures there. And we've been working on these and look at what it would be to contract it. We think that the Georgia GNLC, the Georgia Nursing Leadership Coalition, could make this happen in conjunction with these two boards and working through the workforce board. And so that we would have a plan at the end of the year. Now, I have a lot of experience with workforce planning. For example, I was on the Governor's Task Force in South Carolina. I was in the System Task Force in Illinois. I chaired the System Task Force here. So once you set your goals and you assess and you set your goals, a lot of action happens. We don't have anything like that in Georgia, and we are offering to do that as a coalition of nurse leaders. And these are deans and hospital CNOs and so on, the people that have earned high degrees and epidemiological backgrounds and other kinds of research. So in closing, Chairman Parrish, we have asked for funding of $489 for the first part, the data modernization, and $910,000 for the statewide master planning. We appreciate your consideration and thank you very much.
Thank you. Any questions from the committee? Thank you. Next, we're going to have Dave Lamb, and that'll be followed by Tom Bauer.
Thank you, Mr. Chairman, members of the community. I'm Dave Lamb. I'm with the Georgia chapter of the Home Care Association of America. I do have a presentation, but we've left handouts. Each of you should have your own individualized handout that shows your area as far as aging data. And on the presentation, I'm going to skip right through to page 6 and want to talk with you about using the Georgia CNA registry as an indication of the caregiver workforce that is serving Georgians in their home and communities. That registry is down 12% since 2009. And we need another 61.5% just to meet the needs projected in the year 2030. Right now, aging Georgians are about 1.5 million. OPB projects that by 2030, we'll have roughly 2.4 million Georgians over the age of 65. Now, what's happening on a county basis? 112 counties have lost workforce. If you'll turn to the next page, you'll see that in Georgia, as an average, 25 elderly per every CNA on the registry. 9 years ago, that was 17, so that's a 47% difference. Now, we're all looking for the same caregivers, and the chart there shows you that home care and community care, typically reimbursement rates keep our pay rates about $4 an hour lower. The next page kind of delineates information that y'all used last year. Y'all gave us a rate increase last year of 10%, and our industry greatly appreciates that. For the home care portion of the industry, that was the first increase since October of 2014. But I've given you there gaps that look at reimbursement rates and cost of living, and it's projected that next year at this time, that gap will have gone from $7.93 an hour to $8.80 an hour. If you'll turn the page, the home care industry has a Home Care Pulse that does an annual benchmarking study. We've used that benchmarking study to build rates and to build them out for you. And the next page at the top has a simplified chart that shows that we would be looking at over $27 an hour of a reimbursement rate for $15 pay rates to have financial stability. And right now, our average blended reimbursement rate is less than $21 an hour. Now, there's other cost inputs that are increasing. The Council of Insurance Agents and Brokers have listed coverage cost increases for the third quarter of last year. Auto up 7.4%, workers' comp down 0.3%, property up 10.3%, general liability up 6.3%, umbrella up almost 17%, and cybersecurity, and we need to be even more concerned about that today, up over 27%. Now, we've got onboarding costs that have increased. Our industry for approaching 3 years have been fingerprinting all of our new hires, all of our applicants. And that's an important part of the process to ensure that these folks are prepared to work in the home and protect our clients and patients. That's a cost of $51.50 per applicant. The other alarming portion is that there are 94 counties without fingerprinting sites that are part of the G-Check system. Also, our PPE costs have increased. So what we are asking for is 2 or 3 things, but the budget item is a 3% increase in this year's budget for Medicaid age blind and disabled that would amount to slightly under $8 million. And that is less than 0.4% of that total state budget for the Medicaid age blind and disabled. We'd also like to see a caregiver Medicaid waiver benefit created where caregivers that work at least 30 hours, consider that full-time, at least 30 hours a week, that they qualify for Medicaid. But again, want to thank you for that. Want to thank you also for last Friday passing a resolution to recognize Friday as National Caregivers Days. Any questions?
Thank you. Any
I've
questions?
left you plenty of contact information. Please do not hesitate to contact me.
Thank you, sir.
Thank y'all.
Okay, next is Tom Bauer, and that'll be followed by Mindy Benderman.
Thank you, Mr. Chairman, members of the committee. I'm Tom Bauer with Leading Age Georgia. We represent a range of senior services, everything from Meals on Wheels and adult day to upscale retirement and HUD high rises. We provide care on the whole continuum of care, but I'm here today to speak on behalf of our adult day health centers, which are under our umbrella. I'm going to mention two things. One, adult day centers provide medical oversight and social interaction for seniors and get them out of the house, thereby freeing their caregivers so they can work. About half of our clients in adult day do have some form of dementia. We too, as Mr. Lamb said, appreciate very much the 10% increase in home community-based services rate, and that's one of my requests is that it be made permanent. And I know it was your intent to do that, and I want to thank Representative Petrie for all his work on that. I know he's worked tirelessly on that. The other thing I want to mention is how much the adult day industry was devastated by COVID. Unlike a lot of home and community-based services, they had to close because of, people couldn't go there because of infection. And now once we've sort of come out of it, we find that about 30 centers have closed throughout the state, a lot of them rural, and our centers lost about $4.7 million. One of the ways we think we could have some relief is I wanted to mention to you is retainer payments. These are payments that were part of the original CARES Act in the first wave of federal funding. And under that, the adult day centers got 3 months worth of funding based upon how many clients they would have had that month in lieu of, so it's sort of like the, I guess the payroll protection that folks got, but for these businesses. Under the American Rescue Plan, very specific, one of the provisions is in addition to all the grants that I think you've probably heard about that the governor's office has been looking at, under Medicaid, each state received a 10% increase in their federal participation to be used for home and community-based services. And each state had to submit a plan to CMS. Ours has been partially approved, but I wanted to specifically mention that under the guidance from CMS for these FMAP plans, states could give another 3 months worth of retainer payments. And we would very much like some legislative help in encouraging the state and DCH to do that. Unlike the previous retainer payments under the CARES Act, there's not even a state match. And this would really go a long way to help our devastated industry that's trying to stay open to provide help to our seniors. So we would hope you would look into those retainer payments for us.
Good. Thank you. Any questions, comments from the committee? Thanks, sir. Thank you. Next, Mindy Benderman, and followed by Sharon Bradshaw.
Good afternoon, Mr. Chairman and members of the committee. I'm Mindy Benderman. I'm the Executive Director of GEARS, the Georgia Early Education Alliance for Ready Students. We work throughout the state of Georgia and we advocate for children ages 0 to 5 and their families. It's my honor to come before you today to present our comments both for GEARS and for Voices for Georgia's Children, our partner, as my colleague Polly McKinney is unable to be here. So I'm presenting for both of us today. I think you also have her written comments. We're asking for your support for 2 items in the DPH budget. Well, for 2 additional items for the DPH budget. The first is evidence-based home visiting, and the second is the DPH lead testing program. During the first 2 years of children's lives, their brains are developing most rapidly. They form about 1 million neural connections per second. And like when we build a house, we need to build the strong foundation in a child's first 5 years that can help invest to support early brain development and ultimately lifelong physical and mental health, school readiness, and future success. So we first ask for you to fund voluntary home visiting programs that are overseen, as I said, by DPH. These voluntary evidence-based home visiting programs provide families with wraparound support that promotes healthy pregnancies, births, and the child's first few years of life. In Georgia, there are roughly 60 rural counties with no practicing pediatrician and roughly 75 without an OBGYN. These voluntary home visitors and home visiting programs can bring health education and services directly to a family's home. They can eliminate transportation and child care barriers and connect families to early intervention services, education, and job opportunities. An addition of $6.5 million in the budget would bring these evidence-based home visiting services to 21 high-need rural counties and provide access to an evidence-based program that we know prevents infant and maternal mortality and child maltreatment. You have a brief in front of you that provides a lot of details about home visiting, but I want to pull out just a couple of results that our current program has for Georgia's families. In 2020, more than 23,000 home visits were conducted for nearly 2,000 Georgia families. And of these families, 99% had no record of maltreatment. 83% of children who were served were screened for developmental delays at the appropriate time. 76% of moms received postpartum care. And 87% used safe sleep practices due to intervention and support by these trained home visitors. These programs can save Georgia money. They can save lives of our children and our moms, and they can put kids on a path to be ready for school and healthy for life. So again, we hope that you will provide these funds to support these additional rural counties who have no home visiting programs. Our second ask is for funds for the DPH lead testing program, pending passage of Chairman Dempsey's House Bill 1355, which would bring Georgia into compliance with federal blood lead level recommendations. We believe it would take about $1.8 million to give DPH what it needs to bring this agency's lead testing program to the level the bill would require. And we think this is important because children's bodies absorb lead more easily. It affects brain development, physical development, organs, and the nervous system. And even very low levels of lead can result in speech, language, and behavioral problems, lower IQs for these children, and attention deficit disorder. These create lifelong problems for our education system, for our families, and most importantly, for our children that can be prevented. And blood lead testing is one of the tools we have to prevent this, and we hope that you will provide funds. I remain willing and available for any questions you may have now or in the future, and I thank you hopefully for your support.
Thank you. Any comments or questions from the committee? Thank you. Next, Sharon, whoops. Hard to operate all this stuff.
Hi, good afternoon, and thank you to Chairman Parrish and all the committee members. Thank you for having me today. My name is Sharon Bradshaw, and I am a caregiver with Advanced Care Partners, a home health care agency. And I'm here representing nursing, skilled nursing services that we provide, and asking for to continue with the increase for our GAP program to provide skilled nursing services into the homes. I just want to tell you from a nursing standpoint, I have worked with a little boy with our agency for about 2 years now. And this little boy, he has cystic fibrosis. He's continuous G-tube fed. And I always just go to the home and help the family with him by providing at least 24 hours a week of nursing care. I wanted to let you know that the importance of us going into these homes is to support the family, and not just the family, but the child as well, the development of this child. So going into this home on 3 days a week from like 7 a.m. to 3 p.m., I'm able to go in and speak with the child, provide care for this child. And I've been, when he started with us, he could not speak. He's developmentally delayed, and he couldn't eat by mouth. And so over time, as I accompanied him and the foster parent to the appointments into speech and physical therapy and occupational therapy, I was able to provide those services throughout the week when he did not receive those therapies. He had to go to those sites and centers. And so working with him, I was able to sit back and watch him grow, watch him take his first steps, watch him for the first time ever eat some food where he was not able to eat anything by mouth, and just see his little expression. Our company and as a nurse overall, we provide patient-centered care, and not just patient-centered care, but family-centered care as well. We provide all of the comfort and the encouragement and support to the child as well as the family. And so what we provide as nurses goes far beyond just book knowledge and medications and doctor's appointments. We actually are there as extra support system for their family. I had the privilege of working with this little boy, and like I said, he took his first word where he couldn't speak. My name is Sharon, and so he would always call me China. And I'd be like, okay, that's not my name. My name is not Chinese. But I knew he knew who I was. And at the end of the shift, when I would go home, I would say, okay, I love you. And he said, I love you too, Chinese. So that was worth more than anything else in this world. Also being able to be that support for the family. The foster mom has other foster kids in the home. She works, and the husband also works. And she had stated, I have not been able to go to the salon for over the past 2 years due to working. And I have not been on a date with my husband in so long. And just listening to her, and because of the hours that she receives nursing services, our company, she talked with the scheduler, and I said, you know what? Just because I work 7 to 3, you can actually call the company and ask them, to kind of switch the hours around, and I'll be more than happy to come and work 3 to 11 shifts. And that meant something to them. And she said, would you really do that? And I was like, yeah. So I went to the home 3 to 11 on a Friday evening to allow her and her husband that one opportunity to go out on a date. I watched, did my job, my 8-hour shift. Their teenage daughters watched the other kids in the home. And I was able to provide that extra something for them that goes far beyond money and anything else that you can actually give or do for a person. And so with the increase in funding for the GAP program, you allow nurses like myself to go in and provide that care, and also provide that extra support in what the families actually need. It's hard right now because we're competing against health staffing agencies that are paying all these astronomical amount of dollars to employ nurses. I'm not knocking that, but we can't compete with that. Home health care agencies, we can't compete with that. I could very well go somewhere else and work with a home health care agency and make all that money, or go to a staffing agency. But the reason I do what I do is, number one, the love for my profession. I love everything about being a nurse. I love this profession, love for the mission of my company. I love what we stand for. And most of all, the love for the patients and the families that we provide services for. So if you could if there's any way that you can and that you will you increase the amount of the gap rate so that we can continue to employ nurses like myself to go into these homes and to provide the services that the patient needs, as well as providing the family-centered care that they need as well. So if you would, I thank you also for allowing me to stand here and just address you on today from a nursing standpoint, and just to let you know that we need your support, we need your help in order for us to help the families in the state of Georgia to provide that care for those individuals. We're just asking, and I'm asking on behalf of every nurse in this state, that if you would just allow us to have the money to the different agencies that we will give, so we can provide that care to everybody in this state, not just for advanced care partners. Thank you.
Thank you, ma'am. Any questions from the committee? Thank you very
You're
much.
welcome.
Next, Cheryl Gabram, and followed by Brian Ginn.
Thank you, Mr. Chairman. What a compelling story, by the way, a hard act to follow. I am Dr. Cheryl Gabram, the Chief Scientific Officer from the Georgia Center for Oncology Research and Education, and a surgical oncologist. I'm pleased to be here today to support the Department of Community Health funding requests that will pay for routine medical costs associated with participation in clinical trials by Georgia's Medicaid patients. Georgia Core has worked for nearly 20 years to bring clinical trials to Georgia so Georgians can stay in their home state to receive the most advanced cancer care available. There has been an 8-fold increase in the number of clinical cancer trials, currently over 800 available in Georgia. We appreciate your support of this line item so Medicaid clients have access to clinical trials like many others in the state. And I thank you for your time.
Thank you. Any questions? Thank you, ma'am. All right. Brian Ginn, followed by Carl Leachman.
Chairman Parrish and members of the committee, good afternoon. My name is Brian Ginn. I am privileged to serve as the Chief Campus Officer at PCOM Georgia, with campuses in Suwannee, Gwinnett County, and in Moultrie, Colquitt County. In 2005, PCOM Georgia opened its doors to educate physicians and health practitioners for the state of Georgia and the southeastern United States. And in 2019, we redoubled our efforts and commitment to the state by building and opening PCOM South Georgia and Moultrie. Since that time, PCOM and PCOM South Georgia now enroll 1,319 students in academic programs to include osteopathic medicine, pharmacy, physical therapy, and master's programs in biomedical sciences, physician assistant studies, and a new program that's coming online this year, a master's in biomedical laboratory sciences program, which we have heard is a significant need in the state of Georgia. PCOM graduates our graduates are typically staying in primary care professions at the rate of about 70% or more. And so we're delighted that hospitals, with your support, Mr. Chairman, are creating residencies that allow our students to stay in the state of Georgia. And we're seeing that happen more and more at a significant clip and a significant rate. So we appreciate your support of residency education as well. PCOM Georgia and PCOM South Georgia are fully committed to meeting the needs of the state. And through the partnership with the state of Georgia, we believe that we can do even more. Our local community in Colquitt County, for example, has put on the table another $4.8 million in matching funds to support academic program expansion in the southern part of the state. And so we commend to the committee your consideration of that matching fund request that has been provided by the local community. We appreciate the GEARS funding that Governor Kemp and the Office of Planning and Budget has provided that allows us to address some of the COVID-related expenses that we have had. And that also includes funding for pathways programs that we're working diligently to ensure that we're educating and providing opportunities for students at high schools and others to understand what the health professions offer for them in the future if they wish to move in that direction. We have recently signed articulation agreements to fast track students to medical school with institutions to include Georgia Southern University, Valdosta State, ABAC, and multiple other university system schools around the state of Georgia. And we're excited about those articulation agreements that bring students to our campuses. And we want you to know that our total enrollment in Georgia over the last year was 1,319. And I will tell you that about 65% of those students are coming from the state of Georgia. And we're increasingly seeing more and more and more of our citizen students coming to PCOM here and then staying here. And I would suggest to you, Mr. Chairman, that those who come to us from out of state are finding that they love Georgia and they are tending to stay here as well, both in all around the state as they have the opportunity to rotate on medical rotations all around the state of Georgia. So, Mr. Chairman, we appreciate the work that that this committee does, and we appreciate the partnership that you've expended with us in the past, and we appreciate the precedent that the state of Georgia has put on the table in the past for support of medical education at private institutions in the state. So with that, Mr. Chairman, I'd be happy to answer any questions.
Thank you. Any questions for the presenter? Thank you.
Thank you, Mr. Chairman.
Carl Leachman, and then Damian Carbezas and Brenda Cabalas. Mercy Care next.
Chairman Parrish, thank you for this opportunity, and committee members. I'm Carl. I'm the Executive Director of Childkind, and Childkind is a provider of services for children with complex medical conditions, developmental disabilities, or severe maladaptive behaviors. But we developed a parenting model we call Take Charge for children and families of children with medical complexity. And our ask is, we're seeking to pilot this program. We're asking for $1,950,000 spread out over 3 years, so roughly $650,000 a year, to pilot the program in 3 areas. We're looking at Metro Atlanta, where we've run the model in the past and have had it evaluated, and 2 other parts of the state. So the reason I think it's worth your look is that we believe, based on an evaluation by the Department of Community Health in 2015, looking at discharge data from the children and the families that were served under the program, that their Medicaid claims dropped by 49% over 2 years. And Department of Community Health researcher also developed a control group to compare, and we doubled the outcomes based on that control group. And the way the model works, it's actually quite simple, that we work with each family. The family would be referred to Childkind, typically by a medical specialist, a gastroenterologist, neurologist, any kind of medical specialist, when they're concerned about the ability of the family to manage the care of the child. And so we developed a matrix of 4 different components to the program to work with the family to ensure their sustainability, because obviously the objective of the program is to keep the family together intact, keep them out of state custody, and ensure the well-being of the child. So we look at 4 different quadrants. One is helping parents learn how to bond with their child, and this is exceedingly important when the child does not have a more typical physical means of communication with the parent. Another area is we'll train the family on the regimens of care for the child to make sure they understand what they're supposed to do, that they master anything from trach suctioning to G-tube feeding to the medicine administration. We'll also accompany the parents to the specialists to make sure the parent understands the instructions they're being given on how to care for the child. And then we also look at the parent, what we call parenting sustainability. And that is exceedingly important for these parents to have a support group of friends or relatives or someone who can help shoulder the burden with the family for this child. And then the other component is a little bit different than what's done here. We call family sustainability. And we believe, and our experience has shown, it's important that these families and the parents learn how to be their own care coordinator and learn how to be their own case manager. And we have different tools, and we'll teach them how to navigate this complicated system. And again, based on Department of Community Health data, we believe over the course of the 3-year project, we could save the state over $12 million net of expenses in this project. So let me just give you a short story as an example of a child that we worked with. We'll work with any family, any child 0 to 18. The only qualification is that they have to have a complex medical condition. And in the very fine print, and I hope you have glasses down there, it just gives you the list of the medical diagnoses that were involved with the families that Department of Community Health studied. So we worked with a family. This was a 11th grade student in Henry County Schools, and she was an honor student. She was on her way to college. She was a cheerleader, but she had an undiagnosed heart condition and had a cardiac arrest at a roller skating rink. And by the time they thought she just fell and hurt herself, but by the time she got to the hospital, she had a traumatic brain injury. And she became a total care needs child, round the clock care. And her mother tried to apply, single parent, tried to apply for different support services. She was turned down because her income was too high. The school system gave her daughter an honorary high school diploma, which cut her off from IDEA mandated school services. So the long and short of it, she was left with nothing. And because the traumatic brain injury was not caused by physical trauma, you know, she had a cardiac arrest, fell, then hit her head, but because it was caused by the cardiac arrest, she didn't qualify for the brain injury trust fund grant. So she lost her job, her home was foreclosed on, and her car was repossessed. And that's when we encountered this parent. So we will work with, again, any child. We don't care what the age is, can be an infant. And the important thing to recognize is that this population, children with medical complexity, nationwide, they're 6% of the Medicaid population and 40% of the Medicaid billings. So if you want to cut Medicaid costs, you look at this population, not by cutting services, but by looking at all the barriers and all the supports and services families are going to need in order to be sustainable. And this project is something that I believe has documented success at doing it. So thank you very much.
Thank you. Any comments or questions from the committee? Thank you. Okay, next, Damian Carbaza and Brenda Fabulas, maybe? Okay. And then it'll be followed by Daniel Rogers.
Thank you, Chairman Parrish and members of the Health Subcommittee. Thank you for the opportunity to speak today. I'm Damian Cabezas. I'm the president of Mercy Care, started in October of last year, and I am looking forward to working with you all and meeting you. And again, thank you for the opportunity for allowing us to speak today. We're not here for a specific ask. We're here basically to support the discussion around Medicaid reimbursement for therapeutic services, Medicaid reimbursement for psychiatric services, and behavioral health services. Mercy Care has been providing a healing presence since the 1980s to those that are homeless, underinsured, or not insured at all. And as a federally qualified health center, we provide primary care, dental services, vision services, behavioral health services. But more importantly, we restore the dignity of every person that comes to see us. And why that's important is because when you restore dignity, when you restore self-confidence, people will then seek services other than the criminal justice system, which is costlier, or emergency rooms. They'll seek services such as ours and other services that are lower cost and higher outcomes. We serve about 16,000 patients a year, and that involves about 53 encounters that, again, ranges from primary care to behavioral health to dental to case management. Again, we're just seeking support to continue to expand initiatives and funding for behavioral health. We are excited that we have an expansion going on at downtown Atlanta in our Decatur Street location. And we're hopeful that all of you can come to our ribbon cutting in April. But we're able to serve an additional 1,000 patients at that location, specifically those with behavioral health needs, high mental health and behavioral health needs. And we will need the resources for it because, again, not only are we providing the core services that I mentioned, but we're also excited about scaling the social determinants of health, addressing the social determinants of health, housing, employment, education. We're scaling a pilot that we've done to address those social determinants of health because we all know that without stable housing, individuals can't get back on the road to recovery. So thank you again. I'm going to turn it over to my colleague, and I look forward to, again, meeting and working with you.
Thank you, Damian, for that great overview. I'm Brenda Sabolis, and I'm the Director of Behavioral Health and Social Services. I'm also an advanced practice nurse at Mercy Care. And we came specifically today to talk about this low income Medicaid expansion with the child and adolescent therapeutic services and the psychiatric, behavioral health, and case management services. We feel like we now have a lot of experience with this to tell you about. We had developed a partnership with Children's Healthcare of Atlanta to be able to bring to our integrated behavioral health program, the outpatient pediatric services for children. And you know that for those children who have Medicaid, you know that that is not the most desirable insurance for many companies. And so we have brought that to Mercy Care, where we can see the children not only through the pediatric evaluations, but in an integrated behavioral health approach. They can be seen by a behavioral health consultant. They can have a consultation or evaluation with a psychiatrist or advanced practice nurse, and then benefit from the case management services. So what we have found that we really want to communicate to you in regards to your consideration of your Medicaid expansion is that on a single day, these families who do not have all the money for transportation, their housing may not be stable, they have financial issues, and finally, they actually have food issues. So while we work with their social determinants of health, they may not be able to go to a pediatrician here, a behavioral health person there, you know, in the more traditional sense, because their needs are very, very current. And so when they can have these services under one roof, not to mention also the little dental chairs that we have and the vision services that we have, when they can do that under one roof, we can really, really make some immediate gains much more efficiently at less cost when we are working as a team for these children and adolescents. You know, statistics show that half of all mental health and substance use disorder behaviors start by age 14. And when you're looking at what the pediatrician is seeing and behavioral health, and you can actually intervene at that time, you can make great headway into the later statistic that 25% of all Americans, 1 in 4, are going to have a mental health or SUD diagnosis by the time they die. So in this population, what is equally important, and we have a huge forward motion with the evaluation of social determinants of health, because we know if people don't have stable housing, I mean, that's a health intervention. Food and nutrition is a health intervention. All of these things are really important to be able to affect proper health on all of these folks. So we're actually creating a resource center, but we need case management to be paid for, because case management now in the population that we serve in this Tri-County and outward area is absolutely necessary and supportive to make sure that the gains being realized by being able to see in an integrated behavioral health approach to see those gains come to fruition. So we really thank you for the opportunity to be able to express to you what we're seeing and ask for your assistance to help us be able to cement more of these gains. Thank you very much. Are there questions?
Thank you. Any comments or questions from the committee? Thank
Okay,
you.
thank you very much.
Daniel Rogers and it was Tanya Anderson next.
Afternoon, Chairman and members of the subcommittee. I appreciate you giving me just a few minutes to speak to you today. My name is Dr. Daniel Rogers. I'm a licensed psychologist, and I'm also the chair of the Georgia Psychological Association's Legal and Legislative Committee. And I wanted to just take a few moments today and call your attention to a problem, but also a solution, and that I hope you can support. Georgia has a shortage of competent mental health professionals. Although some of the causes of that shortage, as well as some of the solutions, are fairly complex, others are far simpler. I want to draw your attention today to one solution that I think is a low-hanging fruit. Current Georgia Medicaid rules do not allow billing for services provided by psychology doctoral interns and postdoctoral residents. Although those individuals are not yet licensed as psychologists, they are very close to that point. Those two groups of trainees normally possess 4 to 7 years of graduate level training. They are very close to being full experts when it comes to the assessment and diagnosis and treatment of mental health issues. They are equipped to, and they actually are already providing high quality services. They're working under the supervision of licensed psychologists, and in many cases, they're working in settings that serve some of our most needy citizens. For example, these psychology interns and postdocs are working in such places as CHOA, the Medical College of Georgia, Georgia Regional Hospital, and Emory's University in the Department of Psychiatry and Behavioral Sciences. If those trainee services were eligible for Medicaid reimbursement, it would positively impact mental health services in Georgia in 3 ways. First, it immediately expands the number of Medicaid providers. Second, it would encourage the existing intern and postdoc programs in Georgia to expand the number of training positions that they have. And third, it would incentivize the creation of new intern and postdoctoral training programs. I'll draw your attention to 2 precedents I think exist for making this kind of change. First, other states allow psychology interns and postdocs to be reimbursed by Medicaid. This includes such states as Alabama, Texas, Oklahoma, Ohio, Nevada, and South Carolina. Second, here in Georgia, Medicaid rules allow for the reimbursement of services that are provided by medical residents when they're working under the supervision of a physician. I would argue to you that the permissions that we could create for psychology trainees could follow similar guidelines. I understand that the solution I'm proposing to you requires a Medicaid state plan amendment, and I'm hopeful that you would see fit to include in the budget, perhaps under Section 17.4, which is the Healthcare Access and Improvement section, language that would direct DCH to address this issue. I welcome any support that the committee sees fit to provide, because I believe this effort stands to really help increase the amount of Medicaid providers we have to serve the mental health needs of Georgians. I provide you with copies of my comments as well as a position statement from the Georgia Psych Association, and I would welcome any questions now or at a later time. Thank you for your time.
Thank you. Any comments, questions? Thanks, sir. Tanya Anderson and then Cami Wolf-Rice. Thank you.
Thank you so much, Chairman Parrish and members of the committee, for the opportunity to speak with you this afternoon. My name is Tanya Anderson, and I am the Executive Director for Youth Villages Georgia. Youth Villages Georgia has one of the 6 psychiatric residential treatment facilities that we operate here in the state. And we have the capacity to serve 128 youth every single day that experience mental, emotional, and behavioral health instability. As you may know, youth who are placed in psychiatric residential treatment facilities, also known as PRTFs, are both the most vulnerable and the most challenging to serve in these settings. I'm excited to be able to express my gratitude for the leadership in the Department of Community Health for taking the time to visit and meet with PRTF providers to learn more about our challenges that we experience day to day, while exploring ways to better collaborate on increasing bed availability, timely placements, and reducing recidivism into higher levels of care. We are grateful that DCH has been responsive to our request for a much-needed rate adjustment, as evidenced by the current proposal of using fiscal year 20 PRTF annual cost reports to determine those adjusted rates with the addition of a 5% inflation. We are also grateful that DCH has been instrumental in facilitating the collaboration between Medicaid CMOs and PRTFs to begin addressing other challenges as it relates to authorization for services and lengths of stay. Such collaboration and progress in these two areas, which are rates and authorization for services, benefit children who are both in parental custody and in foster care. We are hopeful that the necessary funding is protected in the budget to support the final approval of the proposed PRTF rate adjustment, and that the committee finds this to be a very valuable investment in meeting the needs of Georgia's children. Thank you again for your time, and I'd be happy to answer any questions that you may have of me.
Thank you. Any questions, comments? Thank you very much.
Thank you.
Next, Cammie Wolf Rice, and it'll be followed by Elizabeth Appleby.
Thank you, Chairman Parrish and the committee. I'd like to first share, this is my son. This is my son, Christopher. And I lost Christopher February 26th, 2016 to the opioid epidemic. We did not know how quickly you can go from being a patient taking a prescribed medicine for an illness to an addict dependent on that same drug. My son went into the hospital with one disease, and he left with a second disease that ultimately took his life. We left the hospital with 90 Oxycontins, and I was feeding him to him every 4 hours per the doctor's instruction. So they say the sixth stage of grief is meaning. I found my meaning in 2018, and I started Christopher Wolf Crusade. We're a 501c3. I am a mom on a mission. The solution that we've come up with is reviewing everything that Christopher didn't have and that I didn't have as his caretaker. We're creating a new position in healthcare. It's called a life care specialist. Look at it as a care coach. They're trained in trauma, anxiety, stress, depression, PTSD, checking the mental health box. They're also trained to tell you about the dangers of the medication that you are taking home and how important it is to taper off quickly. They're there to help you with a personalized pain management plan. It's a position that's been missing in our healthcare system for a very long time. We are piloting this program at Grady Hospital. We've been there for 2 years in the orthopedic trauma unit. The data we have is spot on. We're now ready to execute. The Dean of Medicine at Mercer University called me and we met, and she said, "Do you realize that you have the solution for rural Georgia? It's sustainable, it's scalable, it's affordable. It's hiring people in the community to be these care coaches." So we're partnering with Mercer University and the Innovation Rural Center. We're partnering with Grady. We're partnering with Emory. I have a folder over there. I wasn't sure of the procedures, so I don't have a copy for everyone, but I promise you will have one on your desk at every member moving forward. As I said, I'm a mom on a mission. The anniversary of my son's death is this Saturday. And it's so ironic that I have the pleasure, because I'm up here with my son, that he did not die for no reason, and that he did not sacrifice for 15 years fighting addiction for no reason. This needs to be in place. We know that we need prevention. We know we need education. We know we need mental health resources, and this is all provided and run. And we are respectfully requesting $1 million to launch this program out in rural Georgia over the next 3 years with life care specialists. I thank you for your time, Chairman, and say a prayer for me Saturday.
Thank you. Elizabeth Appleby, and Kay Yoke.
Mr. Chairman, members of the committee, thank you for the opportunity to be with you. My name is Elizabeth Apley. I'm here on behalf of Georgia Advancing Communities Together, Enterprise Community Partners, Presbyterians for a Better Georgia, and 9 to 5 Georgia. I want to support and underscore the testimony previously given by Mindy Benderman on behalf of Voices and Gears in support of funding to the Department of Public Health for childhood-led exposure testing. As you know, Chairman Dempsey's study committee met throughout the summer and fall, providing enormous value in shedding light on the challenges of childhood lead poisoning exposure. Lead is a neurotoxin. There's no safe level at any age, but we know that children are particularly vulnerable. Lead poisoning is also irreversible, and Dr. Chris Rustin, Deputy Commissioner of the Department of Public Health, testified yesterday in committee as they passed House Bill 1355. Thank you for your vote, Chairman Hawkins. That the source of lead exposure for 80% of children with these elevated lead levels was from lead paint. And while lead paint was made unlawful for use in residences in 1978, about a third of the residential dwellings in this country still contain lead paint, both inside and outside. So this bill, which passed unanimously from the House Health and Human Services Committee yesterday, we're working to pass it this year. It includes many of the most significant recommendations of the study committee. It'll bring us in line with CDC and EPA recommendations and guidances. And what it will mean is that more children are being identified with an elevated blood lead level. More lead hazards will be identified, and more will be needed to test and address the abatement obligations in dwellings, in schools, and in daycare centers where children under 6 are present. The bill itself is expressly conditioned on the appropriation of funds to implement the legislation. The Department of Public Health has put together a budget, which I've shared with you, which itemizes what they need in order to carry out House Bill 1355. It comes to an appropriation for DPH in the FY23 budget of $1,795,000 and $1,795,794. Predominantly for the hiring of environmental health specialists, 1 for each of the 18 health districts in the state. That's $1.3 million. The purchase of 6 lead testing machines, the provision of maintenance and replacement for those machines, travel to the sites to be tested, setup costs for computers and monitors, cell phones, operating costs, and supplies. Mr. Chairman, almost 2,000 Georgia children under the age of 6 were identified as having these elevated blood lead levels in 2020. And you should note that that was 25,000 fewer children tested that year than the year before, probably because of the pandemic. Many children are going untested. Their environments are going untreated. That leaves them exposed and vulnerable to higher and more dangerous levels of lead poisoning and the irreversible consequences of that exposure that endure throughout their lifetimes. We believe it's a critical investment to preserve the lives and health of Georgia children, and we urge your consideration of this item in your budget request. I'm happy to answer any questions, and the department is also present.
Thank you. Any questions? Thank you, ma'am.
Thank you, sir.
Kay Yoke, is that right? And Whitney Gregaris.
Thank you, Chairman Parrish and members of the committee for this hearing. My name is Kai Yoke, and I am a manager of government affairs at Beata Home Healthcare. I'm here to testify in support of increased funding for Georgia's pediatric program. And I'll limit my comments because Sharon of Advanced Care Partners already did a wonderful job of articulating the challenges that we face as her perspective as a nurse. Some background about Beata: we are a national not-for-profit organization providing home health care services across a continuum. Here in Georgia, we focus on providing private duty nursing care for medically fragile children. We provide care for 70 clients, but are also part of a pediatric home care coalition who provide care to the 1,700 medically fragile children that are served through GAP. As I know members of this committee are aware, GAP was unintentionally excluded from the HCBS increases that y'all appropriated last session. And as such, this program hasn't seen a rate increase since 2018. And as Sharon already shared, that's leaving providers facing severe workforce challenges that are putting medically fragile children's health at risk. One specific example I will share is that we had a client whose foster mother herself required hospitalization for a surgery that she needed. We were unable to recruit the nurses necessary to fill all of the hours that her child needed care. So her child had to be hospitalized for 12 weeks to the tune of $500,000 to the state for care that could have been provided in the home for $9,000 for that same amount of time. We're super grateful that the Department of Community Health has submitted to CMS a request to increase GAP rates by 10% using ARPA funds. And we just want to make sure the committee is aware of the importance of making those funds permanent so that we don't find ourselves in a situation where those funds are exhausted and the rates have to be rolled back. That's a challenge we're facing in other states, and it would put providers in a disastrous situation, as we're relying on that money to increase wages. We're also recommending, to meet the true need that providers are facing and that medically fragile children are facing, an additional investment of 10% on top of the DCH increase. It would cost the state around $2.5 million to increase the nursing rates for this program, and just under $3 million if you chose to also include the aid reimbursement rate that is also under that program. So just want to thank you all for your time and for your support, and welcome any questions you might have.
Thank you. Any questions from the committee? Thank you. Whitney Gregaris and then Thomas Busey.
Hi, I'm Whitney Griggs. I'm the health policy analyst with Georgians for a Healthy Future, and I will throw Andy Lord under the bus for making my name hard to read. And I apologize that I can't speak louder. And today I'm getting over a regular cold, not the other C word. So I'd like to start off, Georgians for a Healthy Future is a consumer-focused healthcare policy and advocacy nonprofit focused on increasing access to healthcare for all Georgians. And we believe that a key way to do that is through robust funding for our public health infrastructure. We're very thankful to the governor and to this committee for the $5,000 cost of living pay raises that all state workers will see, as well as extending postpartum Medicaid till 12 months. Those additions are going to make a huge difference in how we can serve Georgians. However, there is more to do in our public health infrastructure. Georgia was once one of the first states to champion public health care in the 1930s. And in the 1960s, there was at least one public health nurse in every county. But for the past 30 years, Georgia has ranked at the bottom 10 states for health and well-being, despite being a global health hub. So what we'd like to ask for this year is for the committee to consider strategic and sustained investments in public health. And for example, we'd like to see things like expanding successful evidence-based pilot programs. Dr. Toomey yesterday spoke to their request for increased funding for the PrEP pilot in 2 counties that was derailed a bit during the pandemic. Programs like this are essential to ensuring that Georgians receive innovative access to care. And if we put our funding into pilot programs and continuing these programs, we'll be able to see a big difference. We'd also like to see increased services for medically underserved communities. One example is the evidence-based home visiting program. Extending the program to an additional 23 counties would support both healthy parenting and promote physical and early brain development in children with the greatest needs. We'd also like to see the state hire more local and state public health workers. While the $5,000 cost of living increase is incredibly meaningful to public health workers, Georgia still has relatively low wages for our public health workers compared to other states, and certainly compared to the public health sector. This leads to high staff turnover, which leaves the state less prepared to monitor emerging health threats and address ongoing issues. And then finally, we request the consideration to modernize public health data systems. The pandemic revealed gaps in data systems that support and inform our public health system. Modern, adaptable, and secure data surveillance and analysis systems are imperative to detect new or growing health threats, identify populations at increased risk, and respond quickly with program interventions. And oftentimes, these modernizations can occur through a one-time investment in public health. Thank you for the opportunity to speak to you today.
Thank you. Thomas Busey and then Holly Gibbs.
Thank you, Mr. Chairman, members of the committee. Thomas Busey, Senior Director of Government Relations and Health Policy with the Georgia Dental Association. I'll be very brief. We come before you today requesting Medicaid rate increases on 19 specific identified Medicaid dental codes that were identified by the Georgia Dental Association Medicaid Task Force. I would like to start by being very grateful on behalf of our members to the members of the General Assembly, and this committee in particular. For the past 4 years, the Dental Association has advocated for specific rate increases on different codes. Last year, the legislature was generous enough to award a 3% increase on 15 specific identified codes. And we're proud to report that those codes have personally affected the oral health care of over 1.3 million Georgians. We've provided you all with the codes that we're seeking to increase this year on a handout that I believe you have before you. We would ask that you would consider this in a different way than we've asked you to consider this in the past. Before, we have asked that all the codes be treated the same way, and we've provided you cost estimates to the state before FMAP at 3%, 5%, 7%, and 10%. We've also presented another method for your consideration of bifurcating the potential increase in fees and singling out 2 surgical extraction codes. The impetus behind this is hopefully to recruit more Medicaid oral surgery providers by treating those codes at a higher rate of 10 or 12%. And then the remaining codes being treated traditionally as 3%, 5%, 7%, or 10% increases. That is our request. We know that you know through conversations that we have had the struggles of dental Medicaid in Georgia, the struggles of getting oral health care to rural areas and underserved areas throughout the state. And it's the assertion of the Georgia Dental Association and our over 3,600 members that Medicaid dental fee increases is a terrific way to get that care to where it's needed and increase providers that is delivering that care throughout the state. Thank you, sir.
Any questions, comments from the committee? Thank you. Holly Gibbs, followed by Caitlin Waddell.
Thank you, Mr. Chairman, committee members. Holly Gibbs with the Community Care Providers. We represent Georgia Medicaid providers for home and community-based services, and I have with me Ned Morgans, who is on our board. Kind of echoing what a few have already expressed, we just want to say thank you for the 10% that were put in last year's budget. The community care providers were facing a huge crisis during the pandemic, so y'all recognizing the importance of our services is extremely appreciated. We still haven't received all the funds from July 1. However, most of the rates did increase around mid-December. Some still pending due to CMS delays, so we're making progress. I'm sure you're all aware that the community care providers are facing a huge turnover rate, over 50% to be in fact. So we're really struggling with the cost of keeping up with the state mandated live fingerprints. I understand it's already been addressed for other long-term care providers. So our ask is that it be equally addressed for the community care providers and the same cost methodology that was used for other skilled nursing facilities. And if it's appropriate, I was going to have Ned speak to that a little bit more in detail. And then if you have any questions, he could address them for you.
Thank you, Holly. Thank you, Mr. Chairman and committee members. I am currently serving as the treasurer for the Georgia Association of Community Care Providers. And I'm also a provider myself with Skylark Senior Care. We do home care and adult day health. And first, we do want to thank you very much for the 10% rate increase that we had last year. For many of the providers, that money has been spent very quickly with the workforce crisis that we have right now. I know for especially in that home care industry, those underlying salaries have gone up dramatically and quickly. I know for adult day providers across the state, that money will literally be the difference between surviving, especially in some more rural locations, and not being able to survive. So again, thank you very much for that 10% rate increase. This year, we really want to focus in on some relief for the fingerprint expense. We don't have the exact numbers right at this moment, but we do ask that it be equitably. We do understand that other institutions have had that relief in the past, and we ask that home and community-based service providers are also treated equitably in that cost relief. These expenses are quite onerous, as the Department of Community Health has instituted the wrap-back program. It's become even more onerous as more people have to be fingerprinted and then re-fingerprinted, and each time asked, having to pay that money over and over again, increasing that burden on that. The other part of it is the other costs that are associated with that are the amount of travel time that's involved with that the department does not have enough fingerprinting sites available in different places. As was noted earlier, they're not in each county. In many cases, workers are having to drive 45 minutes to an hour or more to be fingerprinted, which again exacerbates that workforce challenge, increases the costs of this these fingerprinting checks. So respectfully, we do ask for some relief, some equitable relief for the fingerprint expense in compliance with the regulations. Thank you.
Thank you. Any questions from the committee? Thank you. Thanks. Caitlin Waddell, and then Shalika Hodo.
Okay, good afternoon. I think I'm number 23 out of 25, so almost done. I'm Caitlin Waddle, like a duck, and I'm representing the Georgia Academy of Nutrition and Dietetics. I'm a licensed dietitian here in the state. I specifically work with pediatrics, children with autism, feeding disorders, and other swallowing disorders. I'm here today to ask you about a rate increase. Dietitians haven't had a rate increase since our best estimate since 2014. And we're estimating based on the Department of Community Health's data that there's only 6 dietitians credentialed with Medicaid in the state. So a severe deficit. And we really hope that this rate increase will incent more dietitians to enroll in the program. Licensed dietitians provide medical nutrition therapy for the treatment of a variety of diseases and conditions, including obesity and other chronic diseases. So we thank you for your support and for listening today. Any questions?
Committee? Thank you.
Okay, thanks.
Shamika Hodu, and then Speaker Terry Coleman.
Good afternoon, Chairman Parrish and members of the committee. And thank you for the opportunity to shed light on key budget items that improve maternal and infant health outcomes here in the state of Georgia. My name is Shomiki Ahodo, and I'm representing March of Dimes Georgia Market, where we lead the fight for all moms and babies. And we know that by improving the health of women before, during, and after pregnancies, we can improve overall health and outcomes for all. And we're so excited that the Georgia General Assembly is considering several of these solutions to these challenges, and March of Dimes Georgia Market would like to speak in support of three in particular. First, March of Dimes would like to voice our support for the appropriation to fund the extension of Medicaid postpartum extension from 6 to 12 months. Women are at risk for pregnancy-related mortality and morbidity throughout the first year and after delivery. And according to the Georgia Maternal Mortality Review Committee, of the 516 cases reviewed from 2012 to 2017, 39% of those cases were determined to be pregnancy-related, and 75% of those pregnancy-related cases were determined to be preventable. Access to medical care during the postpartum period can be a critical tool in addressing the state's maternal mortality crisis. Medicaid has played a long and important role in financing healthcare for low-income pregnant women, covering a vulnerable population and promoting healthy birth outcomes for all. Pregnancy Medicaid covers a range of necessary and important medical services for eligible pregnant women. However, this coverage ends at 6 months after delivery, resulting in many mothers losing health coverage during the critical period, 1 full year postpartum when maternal risk is still prevalent. Extending access to healthcare coverage to 1 year postpartum can ensure the medical and behavioral health conditions can be managed and treated before becoming progressively severe and or before another pregnancy. More than half of the births in Georgia are covered by Medicaid, and extending the period of postpartum coverage, the state has a huge opportunity to improve women's health and birth outcomes. We are so pleased that the governor's included funding for postpartum Medicaid extension through 1 year and urge the subcommittee to support this funding. Similarly, March of Dimes supports funding to cover Medicaid reimbursement for donor breast milk coverage. Georgia ranks 6th highest in preterm birth rates in the nation based on 30 babies born 37 completed weeks of gestation. Each year, 2,200 babies are born in Georgia weighing less than 3.5 pounds, which is considered very low birth weight. These babies are at risk for necrotizing enterocolitis, a disease of the intestines that is devastating to families and costly to the healthcare system overall. Half of the babies who need surgery from NEC will not survive, and this contributes in part to Georgia having the 3rd highest infant mortality rate in the US. NEC is costly to treat. That's why prevention in premature infants is critical. The estimated short-term cost of hospitalization costs for each baby afflicted with NEC ranges from $74,000 to $400,000. Unfortunately, many mothers of infants born premature or very low birth rate are unable to produce enough milk to satisfy the dietary needs of their infants. When a mother cannot provide the necessary breast milk for herself, donor breast milk serves as an efficient alternative, providing similar benefits for those vulnerable newborns. Again, we are pleased that the governor included funding for this appropriation in the budget and recommend that this subcommittee supports this funding. Lastly, I want to ask for funding to be added to expand Georgia's evidence-based home visiting program. Evidence-based home visiting programs connect expectant parents with trained providers to improve developmental, educational, and health outcomes for young children. These programs help ensure that mothers receive adequate prenatal care and to promote healthy behaviors such as smoking cessation and maintaining a healthy diet. Evidence-based home visiting has been shown to improve the lives and prospects of children by helping to reduce the risk of premature birth, low birth weight infants, birth defects, and maternal and infant mortality. The Maternal, Infant, and Early Childhood Home Visiting Program 2020 Needs Assessment Update conducted by the Department of Public Health provided Georgia with the opportunity to identify potentially at-risk counties using county-level indicators such as socioeconomic status, adverse perinatal outcomes, child maltreatment, crime, substance abuse, and disorder. Using these metrics, 48 counties were identified to be at risk, But currently there are only 25 counties receiving home visiting services. That means 21 at-risk counties are without home visiting programs to support the families. To increase the number of counties and at-risk families to have access in this intervention, Georgia would need to fund specific programs in each of these areas. Currently, home visiting is funded through the Maternal, Infant, and Child Health Care Program, MACV, Title V, the Child Abuse Prevention and Treatment Act, and Family First Prevention Act services. State agencies combine funding for home visiting sites in communities using these federal dollars. The Department of Public Health administers evidence-based home visiting, and the University of Georgia provides technical assistance for these sites. Currently, there are no state funds allocated for evidence-based home visiting in Georgia, one of only a few states that are unfortunate with this unfortunate distinction. March of Dimes urges legislators to invest $6.5 million to serve an additional 21 at-risk counties for Georgia's evidence-based home visiting program. Thank you.
Thank
Any
you.
questions?
Any questions from the committee? Thank you very much.
Thank you.
Speaker Emeritus Terry Coleman.
Well, good afternoon, members of the committee. Mr. Chairman, since you completely ignored my request for fiscal year 22, I thought I'd come up here in person and in front of witnesses and give you my request on bended knee. As you know, one of my passions has been medical education, graduate medical education in particular. And I'm asking you to consider today of helping 3 hospitals similar to the way you did in 2013 when Governor Deal did his program. Southern Regional Medical Center in Clayton County is a 300-bed hospital in a fairly tough economic situation in the county and in the region. They are planning to do 10 per year in internal medicine residency. Hopefully they'll apply. They have their application ready in August. I talked with Dr. Mandati today, the Vikram Mandati, who is the chief medical officer. He assured me that they'd have their application ready. You were kind enough to give them $150,000 last year to do the planning. And we hope that if they're successful in getting their internal medicine program going, that they are discussing adding right behind that probably 4 to 6 family medicine slots per year. My second request is for 23 funding for Southeast Georgia Health Systems in Brunswick, 250-bed hospital in Glenn County. They have a sister hospital in St. Mary's, a 45-bed hospital, very active hospital. Southeast Georgia Medical Center is asking for probably between 6 and 8. They're still working on the numbers. Family medicine residents per year for 3 years, as you know. Michael Shernick, who was their CEO, retired in December. He was hired to start their GME application as part of his involvement before. They're using the 150 you gave them last year to do the planning for this program, and we think it'll be very successful. As you know, we've had this discussion before of the 600-something slots that Governor Deal approved, had y'all fund in 2013, 14, 15, and on into 16. Only 12 of those came below Macon. And so out of 600 slots, only 12 of those. So, and actually only 100 probably, I don't know if you helped Mercer or not, helped Coliseum in Macon, but they did a really good job in setting up their internal medicine, emergency medicine, a transitional year, and a psych 4 or 5 per year in psych. So this would really help south of I-20 at Southern Regional. It would help in Brunswick on the coast. And we did ask for planning money, a third request. We did ask for planning money for Coffee Regional Medical Center of $150,000. I know that you discussed that maybe with some other people, and I certainly would ask the committee to consider that. So 3 requests, all in graduate medical education area, 2 as incentive money to kick off Southern Regional in Clayton County, Southeast Georgia Health Systems in Brunswick. We're not coming to ask for a specific amount. We've talked with staff and talked with you, and figure for anywhere from $300,000 to $1 million a year has been discussed. I know Mr. Shernick told me this morning that he'd have his application ready. He said it could cost them between $1 and $2 million a year out of pocket the first 3 years. As you know, though, that some of that will be refunded after the 3rd year, but it's still an out-of-pocket expense that they badly need. So we would rely on the wisdom of the subcommittee if you're willing to help us, whatever amount you could do for 3 years as an incentive for funding on those 2 startup programs and some planning money for Coffee Region. If I'd be glad to answer any questions on that, I would like to give you a little bit of information after, see if you have any questions.
Any questions? Go ahead.
I want to tell you about Georgia's other medical school. Georgia's other medical school, that's aside from Medical College of Georgia, Emory, Mercer, and PCOM, the Philadelphia College of Osteopathic Medicine, is another medical school very active in Georgia, and it's Trinity School of Medicine. Those of you who've been around a while might remember Dr. Doug Skelton was our dean. He's now the chancellor. Dr. Francis, forgot her last name all of a sudden. Anyway, but she's the dean now. She was at Medical College of Georgia and at Mercer. And we have approximately 400 students a year graduating. They have established a clinical campus in Warner Robins, where over 200 students are doing their 3rd year clinical, their 3rd year cores, and 4th year electives in cooperation with Med Center Central Georgia, Houston Healthcare, Fairview Park Hospital in Dublin, Dodge County Hospital, Taylor Regional Hospital, and Crisp Regional Hospital Center. So I would extend an invitation to any of you who would like to come one day and visit. If you're down that way, we'd love to show you about a 10,000 square foot clinical campus that we have, and turning out a lot of physicians. One of our physicians is the chief resident in family medicine at Wellstar this year. We had one year before last, the chief resident at Medical College of Georgia in family medicine. And 25% of all the primary care physicians in this country are graduates of offshore schools. Now, though, I would tell you that any school that has graduates who want to practice in the U.S. has to meet the same standards as LCME and the standards set in the Caribbean by CAMHP. So they're mutually agreed to this licensing thing, and it's a great opportunity for us to provide more physicians in Georgia. I'd be glad to answer any questions you might have.
Good. Thank you for that update.
Are you feeling pretty good today?
Well, thank you for being with us today and giving us some information on some things we maybe didn't know about.
Thank you very much.
According to my information, this depletes the list that we had of those who had signed up to speak. If there's anyone here that we have overlooked or omitted, now would be a good time to let us know, and we'll correct that. If not, thank you all for being here. We appreciate your interest and your time. Thank you to members of the committee for being with us this afternoon, and this meeting is adjourned.